Can you guys put in the chat which branch you're from? If you're from MBBS or Unani or Ayurved, so we know what mix of a crowd we have online. So we have MBBS interns attending. I expect you to answer all the questions that I'm asking since you've cleared final year and all of this was a part of your curriculum. Hi everyone, thank you for your patience. We'll start with the session now. So since it's hybrid, I have interns attending offline as well. And you guys are on online. So thank you for joining. Before we start, it's important to know these topics because you're going to be junior doctors, you're going to be graduates soon. And all of this detail, the information that you need to know are actual cases that you see once you go out into the field. So let's start. Now, you guys will not be able to see the presentation. So either you can. So what are we going to learn today? So we're covering three broad topics. One is medical triage. The second is approach to emergencies. So how do you do a primary assessment of emergencies? It's called the ABCDE approach. And I'll teach you the basics of intubation. Now, it's not going to be very fancy, and I'm sure the MBBS interns have already learned all this during their final year. So do interact, do participate, and let me know if you have any questions. Okay, so what is triage? Right. Right. तो तुम्हारे casualty में जो patients आ रहे हैं या तुम generally जो patients देख रहे हो उनको categorize कैसे करते हो? So it's how do you know which patients are to be treated first? Because we work in a resource constricted setting. हमारे पास इतना ही सामान है and बहुत patients हैं, right? And हमारे पास doctors भी कम है. So how do we make sure that the major emergencies get treated first? So that is essentially what triage is. Triage is very quick. It's what we do when you guys are in the casualty. That's how we decide head injury patient hai. So we will see the head injury patient first. It's an MI patient, priority over a cold or a sprain or something like that, right? So that's basically what triage is. Triage can be done in the field when you're at a site of a mass casualty. Suppose there is an earthquake, flood aa gaya hai, you've been called as a doctor, emergency services are there, and you have a lot of patients. Suppose there are 200 patients and there are, say, 20 doctors, right? So how do you make sure that the ones who need immediate care get it first? So that is what triage does. So what it essentially is the greatest good for the greatest number of people. Now, out of so many patients, you will have some casualties. You will, be able to not save everyone. But how do you make sure that most people get the care that they need, right? If you're in a casualty, you have a cold cough patients coming in and you have an MI patient. It's not like you will see those 10 cold cough patients and leave that MI patient, right? Because you know that the MI patient is more likely to be critical, more likely to deteriorate. So that's essentially what triage is in a hospital setting. So how do you do triage? You have to first look at the patient. Half of the diagnosis is made the minute the patient walks in. There is a patient fever ke saath aaya hai, who's sitting on the floor shivering, right? You know this is a patient who needs immediate care. A same fever patient will come who's walking in, he's just like, kal bukhar aaya tha, now I'm fine. But I still feel a little feverish. So even with the same complaints, there is a difference in the severity, right? So that is what it means. So firstly, you look at the patient visual. Second step, chief complaints. Now, a patient who comes with chest pain is different from a patient who comes with fever. A patient who comes with a minor headache is different from a patient who's coming with a severe headache, saying ki dimag phat raha hai, right? Step 3 is focused assessment. Now, if a patient has told you he has a headache, you're not going to go and auscultate his chest, right? जो complaint दे रहा है उस हिसाब से तुम assess करोगे, because you have to be fast. The point of triage is being quick and accurate. Step 4 is you pose a hypothesis. Now you sort of know that it's a chest pain patient. I'm likely to, get an MI or a pericarditis or something like that. So I will think of my diagnosis. कि चलो इसको MI हो सकता है, right? After doing my focused assessment. Step 5 is you determine the acuity. Like I explained, fever patient with shivering, chills, more acute as compared to a fever patient who's walking in pretty stable, things like that. And step 6, you have to reassess. With triage, the basic thing is after you have categorized the patient, you go through them very quickly and then you reassess, because a patient might deteriorate by the time you get to them. For example, yesterday we had a patient who came with hives, allergic reaction, and she came and she was fine, walked in, she's just like, khujli ho raha hai sab jagah, hives hai. We're like, okay, we gave her Avel and Hydrocor injections. 10 minutes after that, she started shivering, right? And her saturation dropped. And then immediately we put her on oxygen. So that is what it means. You have to keep reassessing the patients that are there. That is why when you're in the casualty, I ask you, update kya hai patients ka? Patients ko kya diya hai? Aage kya denge? Things like that. It's not because I want to complete the treatment and send the patient home. It's because I need to know what has happened next. I am reassessing their status. Why do we take a repeat BP of a patient who's been given amlodipine? Because we are reassessing their condition. So effective triage gets the patient to the right place at the right time with the right healthcare provider. Now, if you have a head injury patient who is otherwise stable, you're not going to send him to the medicine resident, or you're not going to call the medicine on call, right? You're going to send him to surgery. So you have to get them to the right provider. If it's a fracture patient, I'm not going to call my medicine resident and be like, come see the patient, right? So you have to know where to send the patient, who to refer to, what sort of further care do they need after your primary assessment. Okay, so for triage, we have an algorithm where on the basis of this algorithm, we decide if the patient can be categorized into different categories. Now, this is called the START triage algorithm. It's very simple. For your level, this is good enough. There have been modifications to this, but let's stick to this for now. How do you start? Now, adult triage is very easy. There are basically only 5 steps. First step, is the patient able to walk? Agar patient khud chal ke aaya hai, he's likely to be stable, right? If a patient has been brought in unconscious, that means there's something serious, right? So first step itself, patient has walked in, looks stable, minor, green category. This triage also works at a site of at a mass casualty site, where a patient who's unconscious or a patient who's walking around, big difference, especially when it's an emergency situation, because you know that patient who's unconscious requires immediate attention, right? Okay. Next, now the patient is not walking. Okay, he's just sitting somewhere and you've been called to the site. What do? You check if they're breathing on their own or not. So spontaneous breathing. So if they're not breathing spontaneously, what do you do next? You check the airway, position the airway, right? Agar airway ke position mein kuch issue hai and you fixed it, then it's fine. If not, if they recover spontaneous breathing, fine, they go into the red category, which is immediate. If they don't, if they're an apnea, which means they're not breathing, they go into black. Black is high risk, right? जैसे अपना traffic light होता है, similarly, the colors in triage are yellow, sort of in the middle, green, minor, red, immediate care needed, expectant, they're likely to die or they're already dead, right? Okay. So it's pretty simple to understand, especially for the people who drive. Then we have spontaneous breathing. If the patient is breathing spontaneously, what do we check next? We check the respiratory rate. Now, according to the triage categories, if the respiratory rate is above 30, means the patient is hyperventilating. Usko saans nahi aa raha hai. If you've ever seen an asthma patient, they'll be breathing very fast, right? So if the respiratory rate you've counted is above 30, then they go into red. Again, immediate management needed. So after that, we have the next step. Now, if the respiratory rate is again below 30, fine. 22, normal respiration, fine. Then you check the perfusion. Now you check the pulse. Pulse is, where do you check the pulse? Respiratory rate? Below 10. That's hypoventilation. I'll come to that. I'll come to that. Yes, I'll come to that. Now, then you check perfusion again. Again, if it's gone very low, you check perfusion. Go on to the next one. Okay, so if the respiratory rate is less than 30, we move on to perfusion. We check our radial pulse. The side of the thumb is your radius, radial pulse, ulnar pulse, right? I'm hoping as interns, all of you know how to take pulse manually because we're very used to pulse ox. Directly लगा देते हैं, दिखा देता है वो 70, 80 pulse, 100 pulse, but manually कोई नहीं लेता. So make it a habit. Every time a pulse ox shows you that the pulse is low or high, make it a habit to count manually. Don't do it for all patients, it's fine. But do it for the ones where you get an abnormal reading. Okay. So you've checked the radial pulse. And you check the capillary refill. Now, what capillary refill is, you press the, what is it? So, क्या कर रहे हो तुम? What you're trying to do is, you're pressing and you're causing the blood flow to stop, right? And then you release it, blood flow comes back again. So that is your capillaries filling. Now, if it is more than 2 seconds, again, red category needs immediate care. That means there is an issue with the perfusion. Your heart is not sending blood well enough to the peripheries. Now, radial pulse is present and the capillary refill time is less than 2 seconds. तुमने दबाया, 2 सेकंड वेट किया, छोड़ा, वापस आ गया. ठीक है, 2 सेकंड के अंदर वापस आया. After that, you check the mental status. Now, is the patient obeying your commands? You're asking the patient, what is your name? Kahan pe ho? Time kya hua hai? We do that, right? Oriented to time, place, person, right? So if they're obeying commands, if they're answering your questions, they're fine. They go into yellow. If they're not obeying commands, right? If they're not responding to you, they go into red. Okay, so this is the basic triage system, 5 steps. Can you guys tell me what are the 5 steps? People online can also unmute themselves and answer. Okay, what are the 5 steps? Able to walk. Nice. That is the second step. Are you sure? You have the algorithm in front of you. It's okay. What is the second step? Able to walk. Able to walk. The first one is able to walk. Second, spontaneous breathing. Third, respiratory rate. Respiratory rate. Next, pulse and perfusion. Last, wait, capillary refill is perfusion. Mental status. Good. 5 steps, right? Very easy to do. You can do it in less than 30 seconds. The more you practice, the more you see patients, the easier it gets. Also, if you guys have any questions online, you can unmute yourself and ask. Is triage clear to everyone? Samjha? Algorithm? Refill hota hai. Anemic patients mein in general, unka hemoglobin is less, right? But that doesn't mean the perfusion is less. what you're checking with capillary refill is if the blood is getting sent enough, right? Anemic patient just has overall less blood. Sometimes depends on the severity of the anemia. अगर बहुत severe है, hemoglobin 6 है, 4.5 है, then yes, capillary refill will be delayed. But most Indian women are anemic. All of us in this room will also be anemic. But not all of us will have a delayed capillary refill time. So it depends on the severity of the anemia. Okay. Since you've all understood it, and I have no other questions, we'll move on to triage in the emergency. So when you have patients come into a hospital, it's very different to seeing patients outside in the field, right? You know, sort of these are the emergencies that you'll see in the hospital. So under the red category, the most urgent ones are road traffic accidents, right? Head injury, tumne dekhe, head injuries, amputated limbs, things like that. Cardiac events. So cardiac event, pain. Any angina patient, chest pain patient, we consider as a priority because they will deteriorate very quickly if they don't get immediate care. Next, any suspected stroke. कोई आया है patient बोल रहा है face में deviation था, ये उनका मुंह ऐसे हिलने टेढ़ा हो गया, right? So any suspected stroke is again urgent emergency. Next, burns. We've had burn patients coming in. I'm not sure if you guys are on YouTube, but burns patient, you have to immediately hydrate because they are so dehydrated. You have to immediately do the dressing. Yeah, Purva? Do you have a question? Okay. Then we move on to yellow. So anything with a mental health crisis. So any psych patient who comes in saying ki withdrawal mein hai, alcohol withdrawal patients, they'll go into a seizure, right? Things like that. So or a schizophrenia patient, they'll try to self-harm. Okay, so things like that. Severe trouble breathing, asthmatic patients, right? Large broken bones, femur का fracture है, road traffic accident हुआ, femur fracture हुआ, immediately you will get an X-ray done, you will call the orthopedic on call, right? Allergic reactions, like I mentioned, the case that came the other day, hives all over, we gave her the treatment, still she deteriorated, right? So you never know with these patients. So it's important to categorize them as urgent. Next, seizure patients. Known case of epilepsy, known case of seizure disorders, or in children especially febrile seizures. बहुत high fever के साथ बच्चा आ रहा है, 5 दिन हो गए fever रुक ही नहीं रहा है, उतर ही नहीं रहा है, दवाई भी दिया है, and फिर आखिरी आया, right? So febrile seizures in children, very important pediatric emergency. Falls. Any patient who has fallen from a height, again polytrauma, head injury, things like that. Less urgent. So any sprained ankle, cough, congestion, these are red में भी जाएगा. Red में जाएगा, but a fall that has a minor injury compared to a head injury. Head injury, then depending on the vital parameters. Head injury patients we get who are stable also, who just have a cut, सिर्फ skin निकला है, things like that. Otherwise, vitally stable. Right? You still get their workup done, you still get their X-ray done, you get a CT done. But you know that patient is relatively stable. A head injury patient who's come in unconscious with a lot of bleeding, you know that patient takes more priority than the other head injury patient. So any patient, any presentation will also have variation. That is what triage teaches you. कि चलो सारे head injury patients है, railway accident हुआ है, we've fallen off of a cliff, something like that. But which head injury patient do you prioritize over the other? So that is again your 5 steps of triage. Less urgent, patients who can be seen on an OPD basis, sprained ankle, toothache, earache, cough, congestion, just suturing chahiye, right? Those patients can be made to wait. Like a cough patient can be made to wait while you see an MI patient. So what happens abroad is, and in other countries, they have designated areas in their casualty to see these kind of things. So once you've done a basic triage and the patient is a category red, emergency, you take them to the resuscitation area. Category yellow, priority, you take them to the acute area. Category green, non-urgent, waiting area. Wait कर सकते हैं, आधा घंटा, 1 घंटा लगे. Once we're done with the emergent patients, we will see you next. Right? If anyone has doubts, you can put it in the chat, since I might not realize if you've unmuted, and I'll get back to your question. Okay, so this is basically what we do in the casualty as well. What your CMOs do is assess the patient, provide immediate care, escalate, right? And this is what you guys will be doing henceforth. Once you go into hospitals as medical officers or you set up your clinic. If a patient comes to you with a chest pain, and if you've done an ECG, you need to be able to read that ECG and escalate. कि हाँ, इसको STEMI है, इसको ECG पे changes हैं, इनको hospital भेजना है. Which is also how we get patients. वो बोलते हैं बाजू वाले डॉक्टर को दिखाया, उन्होंने बोला जाके admit हो जाओ. That patient has done the triage there and sent them ahead, right? So this is a very important to know at every level. Okay, so we have a case. 30-year-old male brought to casualty with a bleeding head injury. Respiratory rate 22. Wrist pulse is palpable. Mental state is unresponsive. Which category is it? Red. Why is it red? Unresponsive. Good. See, it's quick. It didn't take you very long to be like red hai, immediately iske paas jana hai. You have noticed that if I am sitting and making a paper, staff will immediately call me emergency hai, right? All of us get up and go. How do they know that? They do this triage as well, right? Case 2. 15-year-old female found to be not breathing after an accident. Respiratory rate agonal. Wrist non-palpable. Mental status unresponsive. Black. Okay. Anyone online wants to explain why it's black? Okay. Prashant said agonal respiration. Good. Anyone else? Why is it black? Priya said
because
not.
the patient is not breathing and we cannot feel the pulse on the patient and she is unresponsive.
Rest. Good. In these cases, you would still try CPR. You would give a cycle of CPR, and if they're still unresponsive, you can definitely put them to black, right? Okay. Anybody else who disagrees with this? कि नहीं ये black नहीं है, maybe it's red. अरे, what is this? Majority says black. Okay. Next case. A 20-year-old female complaining of crushed lower extremity. Respiratory rate 20. Wrist pulse is palpable. Mental status follows commands. Why? Why yellow or why green? Give me a justification for what. What was the first step? Triage में हमने 5 steps किए थे. Always follow the order, so you will get the right answer. What is the first step? Walk. Crushed lower extremity. Can she walk? Green is out. See, very simple to do. Following command, crushed injury, so yellow follows the command, right? So, why is it not green? Your first step is only gone. And once you've gone and ruled out green, everything is yellow, red, black, right? If you guys, wait, I'll send the triage phone hai. Triage ka main chart bhejti hu. I'll share the triage chart on the group so you can see it live. न्यूरोवैस्कुलर डैमेज है ना, अगर वेसल डैमेज है, ब्लीड करता हुआ आएगा पेशेंट, राइट? तो इतना सीवियर ब्लीडिंग है तो वो चल के नहीं आया होगा, ठीक है, शॉक में होगा वो इमीडिएट. तो कौन सा कलर? रेड. Give me 1 second, I'll share the chart with all of you. Meanwhile, if anyone has questions online, you can ask me. I've shared the PDF. Okay. If you want, you can open and then it'll make it easier to process. Okay. Last case. 40-year-old male complaining of multiple scratches over bilateral elbows. Respiratory rate is 20. Wrist pulse palpable. Mental status follows commands. Which category? Why is it green? Minor scratch. Right. ऐसे पेशेंट्स आते हैं कि नहीं आते? रात को खुजली हो रही है. Right. Right. Get it? Now, this is why we send the patients away and we ask them to come in the OPD because they're not emergent. If I change the history, if I tell you a 40-year-old male complains of multiple scratches over bilateral elbows after a fall, respiratory rate is 33, wrist pulse palpable, mental status disoriented. What is your category? Why is it red? Right. Good. So you see how important it is. Disoriented patient. So you can see how I've just changed one word and a few vitals and the category has completely changed. Right? So that's what it tells you. That's why your history taking, your examination is very important. Okay. Now, primary assessment. You have decided which category the patient is in. You have come to the patient and now you want to assess, right? What do you do? For us, we just start ki ha patient aaya, vitals liya, treatment diya, ho gaya. That is not how you should independently see patients. If you've ever seen me or if you've seen the medicine resident or a surgery resident come in and assess patients, they follow a pattern. Now, you can't see it because no one's explaining it to you out loud. Ki wo kya kar rahe hain, kya dekha unhone. But this is what they do. And this is what you are supposed to do as emergency physicians. So we take the A, B, C, D, E approach. We check the airway, breathing, circulation, disability, and exposure. Again, 5, very simple. Airway. Can the patient talk? Patient comes to you, casualty site pe hai. Patient is sitting somewhere, has bleeding injury somewhere, and the patient is not communicating with you. Ki kya hua? Aise patients aate, they don't talk to you. Yesterday we had a patient who had alcohol, he had desi daru, he had food, vomited once, and then collapsed. Right? So the relatives got him in. He's awake, he's drowsy, and he's not responsive. He has response to pain, but baat nahi kar raha hai. Again, so do we know the airways patent or not? What do we think? Drowsy patient, not talking. कंटेंट निकल गया है, बट एयरवे वो एस्पिरेट कर सकता है ना, तुम्हें एयरवे चेक करना ना उसका, राइट? Then we assess. Right. So you check for breath sounds. You auscultate the lungs. Right. You check the airway. So can the patient talk? Easiest way to understand airway clear hai ya nahi hai. If not, you look for signs of airway compromise. These include cyanosis, seesaw breathing, accessory muscles use कर रहा है. What is cyanosis? Right. Right. Seesaw breathing. Now you have different patterns of breathing that are considered abnormal. Accessory muscles. You're using your normal muscles to breathe normally. If there is any patient who's having trouble in breathing, they'll be using their accessory muscles. Diminished breath sounds. We auscultate the patients. अगर एक साइड सपोज राइट साइड के ब्रेथ साउंड्स नहीं है, ब्रेथलेसनेस के साथ आया है, व्हाट डू यू सस्पेक्ट? You only have breath sounds on the right side, no breath sounds on the left side. What do you suspect? Anyone online wants to try?
Pneumothorax.
Pneumothorax. Good. One differential, pneumothorax. Anyone else? Okay.
Lung collapse.
Yes, Mohit?
Lung collapse.
Yes, lung collapse. Very good. Any operated case. So if he's had a pneumonectomy before, right? So good. That's how you assess. Foreign body in the bronchus, right? Foreign body on one side, block the entry of airway. No chest sounds on, no breath sounds on that side. Good. So that's what you've done. You've assessed the patient, you've examined, you've come to differentials. Okay. Then, if he's not talking, you open the mouth and you inspect. Is there anything that's obstructing the airway? Somebody mentioned foreign body. There can be secretions. जो तुम बोल रहे थे, aspirate कर सकता है. Vomiting patient can aspirate. Foreign body, no breath sounds, right? Yeah, you look for the tongue position. So the tongue itself, if it goes back, it will block the breathing, right? Unconscious patients में fall of the tongue होता है. If for that we put a guard to prevent falling of the tongue. This is all ICU may you will see. If you're in the ICU posted, speak to the residents. Ask them why have they done this. So they'll teach you what have they done for the airway. Things like that. Okay. Suppose you assess the patient is not breathing. What do you do? Now for specific types of patients, you can also use specific maneuvers. You have the head tilt, chin lift. सिर ऊपर करते हैं उसका, right? Patient नहीं breathe कर रहा है, chin lift करते हैं. So that the airway comes in one line and it's easier for the air to enter. You can do a jaw thrust. Now for a cervical spine injury, अगर उसको यहाँ पे injury है, तुम ये करोगे, you will aggravate the injury, right? For them, you will do a jaw thrust. You try to open up their airways, right? So you have, that is why before touching the patient, I have to know उसको हुआ क्या था. Because it's an injury patient, right? Suppose उसको यहाँ पे लगा था, मैंने पूछा नहीं. I have gone lifted the head up. Uska cervical spine will be gone. The nerve here will get damaged, right? The cord. So that is why always history first, then examination. Oropharyngeal airway, you have a nasopharyngeal airway, you can also do CPR. Now you have to know when to do CPR, what conditions you do CPR and how do you start. Depending on the severity of the patient, you choose your next maneuver to do. Okay? I will be covering the airway instruments and everything. Sab hai mere paas. I will explain. Okay, next. A ho gaya. Next. Breathing. B. What do you assess in breathing? You look at the patient's respiratory rate. Same, हमने triage में देखा था, respiratory rate. What is the normal respiratory rate? ठीक है, 12 to 20 तक is fine. Okay, anything below that is bradyapnea. Anything above that, tachyapnea. Right. In the triage categories, we did above 30. So there's a difference. According to those guidelines, they've taken above 30 because again, more acute setting and an asthmatic patient coming with a respiratory rate of say 35, 33, 35. Again, they have considered to be immediate, right? So this is what it means. Not all guidelines are the same. हर hospital के खुद के भी guidelines होते हैं और कुछ standardized guidelines भी होते हैं. Now the start triage guidelines are standard guidelines. Then उसके बाद modifications आते हैं, right? So it depends from hospital to hospital what they want to follow. Okay, what is normal saturation? 94 to 98. Now, if it's a COPD patient, And what happens is, जब हमें patient आके बोलता है breathlessness, saturation is 90, we'll immediately put him on oxygen. But then later we find out he's a chronic smoker. 20 साल से बीड़ी पी रहा है, 20 साल से cigarette पी रहा है. Now in these patients, a saturation of 90 is okay, right? So you have to know that history. Even if you've given him, suppose you started him on 1 liter oxygen, 2 liter oxygen, it's okay, but you have to stop it, right? You have to know what history is relevant to what management you're giving, right? In a COPD patient, they are at high risk of CO2 retention. So their oxygen saturation is between 88 to 92. Okay? What other inspection will you do for breathing? You will look for cyanosis. What are the types of cyanosis? Good. Peripheral and central. What does it mean? बोलो, सही बोल रहे थे. Central is oral, nose, oral mucosa, all of that, right? Central. Your center of the body, peripheries, extremities. Central or surround mark. Good. This cyanosis is especially important in pediatrics. छोटे बच्चे आते हैं, उनके हाथ पैर नीले पड़ जाते हैं. पेशेंट्स आएंगे तुम्हारे पास, पेरेंट्स विल कम कि हाथ पैर नीले पड़ गए हैं. तो दैट्स वेयर यू हैव टू नो, ओके ब्रीदिंग में प्रॉब्लम है, राइट? शॉर्टनेस ऑफ ब्रेथ. शॉर्टनेस ऑफ ब्रेथ मतलब राइट, सांस लेने में तकलीफ है, राइट? Cough. What are the types of cough? Dry मतलब sputum नहीं आएगा. Wet cough. It's also called cough with expectoration, right? So that is the sputum. In which conditions online? In which conditions will you get dry cough? In which conditions will you get cough with expectoration? You can type it in the chat or unmute. Anything is fine. MBBS interns, basic questions. You should know this. LRTI is a very vague term. Lower respiratory tract infections includes a lot. But right, bacterial infections with sputum, viral dry cough, okay. Bronchiectasis, very good. Bronchiectasis has a lot of secretions. One of the classical way you know is bronchiectasis. There'll be like ऐसे glass भर के बलगम निकलता है.
Asthma.
Asthma, good. Asthma is dry or wet?
Dry cough.
Dry cough. Asthma in itself will be dry cough. If there is a superimposed infection, then it can be wet. Tuberculosis, wet cough, okay. Cough with expectoration in infections, bronchiectasis, dry cough. Good answer. Side effect of ACE inhibitors, asthma. Now, a lot of medications that you give, cardiac patients को ACE inhibitors देते हैं. ACE inhibitors का side effect is cough, dry cough. Right? तो वो आएगा patient की, हम हार्ट के पेशेंट है, ये गोली ले रहे हैं, खांसी आते रहता है, आती रहता है, जा ही नहीं रहा है, हमने कफ सिरप भी लिया है, but it's not going. So that's also why drug history is important, especially in case of cough. Asthma, okay. Dry cough, pleurisy, asthma. I think wet cough is infections, bronchitis, pneumonia with sputum. Okay, good. So in general, you're well aware of the diagnosis that you can make after assessing the breathing. What is stridor? Stridor.
Noisy breathing.
क्या sound रहता है? Okay, online. Dry and GERD too. Good. What is stridor? Online.
Stridor is
Inspiratory sound, right?
Stridor is a
Right, go ahead.
obstruction of the airway.
Stridor doesn't always mean obstruction of the airway. It depends. Stridor is narrowing of the airway. Good. Obstruction is different from narrowing. Obstruction means there's no air going in at all, right? That is what obstruction is. Stridor is because of narrowing. There is either secretion, because of which वो घर 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 ऐसे आवाज आता है. कभी auscultate भी करोगे. And usually if you're close to the patient, no, you can hear it normally also. If it's like a very severe infection. High pitched loud sound with musical note due to obstruction in the upper airway tract. Very nice. Right. So again, it's because of narrowing. If you say obstruction means there's no air going in, right? Complete obstruction. Partial obstruction, yes. Then you have to specify it. Yes. Good. High pitched whistling sound, high pitched loud sound. Good. Now there are some abnormal respiration patterns, which I don't know if you guys know. कुछ सुना है कि abnormal respiration patterns क्या होते हैं? Online? Any high level question I'm going to throw online? Cosmal, yes. Cosmal, chain stroke, yes. Anyone who answers has to explain what it is. So Chet, unmute and explain what Kussmaul's breathing is.
I remember it's acidotic breathing, like tachypnea with like deep inspiration, expiration.
Yes, good. Chain stroke, Sanchit.
Any periodic breathing?
Okay, somewhat. But what about periodic? Why is it abnormal?
Alternating apnea and
Okay.
hyperapnea.
ठीक है. Sudhanshu has answered DKA. You're right, but that's not the abnormal pattern. DKA is a diagnosis, right? DKA में एक type का abnormal breathing दिखता है. Prashant has said apneustic, ataxic, bitorts breathing, right? Sanket has said apnea with hyperventilation, crescendo, decrescendo breathing, chain stroke. Okay, so all of this we'll cover in the medicine lecture as well. But these are the certain types of abnormal respiratory patterns. I will send you, if you guys want, I'll send you videos of all of these patterns so you can see what it looks like, right? I'll send it on the group. Bitorts, abrupt hyperapnea with apnea. Good, Ayush. Chain stroke, gradual hyper and apnea. Okay, yes. Okay. Now these are just words to you. You know what is apnea, what is
So,
hyperapnea.
Excuse me.
Yeah, go ahead.
What is the difference between periodic breathing and apnea? What is
That's the
different?
point. It's not just periodic breathing. So when he answered periodic breathing, he has to explain the type of breathing it is. Periodic breathing is just for breathe kar raha hai. There's a pattern, like it's a repeating pattern of breathing that he's doing. But what kind of breathing is it? Right? I'll explain it further. Otherwise, we'll get stuck. So my point being, when you're doing it in theory, they're just words to you. How does it look on the patient is what is important. अब तुम्हारे पास DK का patient आया, you're seeing उसका breathing abnormal है, you know the words are this, but being able to identify it is what's more important. So for that, I'll send you guys videos to see what it all looks like. So if we have time at the end, I'll explain and I'll show you all the breathing patterns. Circulation. See, what do you check? What is the patient's heart rate? Pulse क्या होता है patient का? Normal pulse? 72? 70 to 80? 70 to 90? 72? 70 to 100 is normal. 70 to 90. 60 to 99. Okay. Anything below 60 is Brady. Anything above 99, 100 is tacky. Okay. Pulse ox पे हम लिखते हैं. Suppose patient आया, complains of chest pain. Pulse is 116. We get his ECG done, right? And then on the ECG also, you will get the tachycardia findings. I'll explain on the ECG how to see it later in the next sessions. But that's how it works. So your clinical examination has to correspond with your investigations. Otherwise, something has gone wrong, right? It can't be like पेशेंट तुम्हें पल्स ऑक्स पे तुम्हें 120 पल्स दिखा रहा है, ईसीजी पे कुछ नहीं है, ब्रेडिकार्डिया दिखा रहा है, राइट? नाउ ईदर द पल्स ऑक्स इज स्पॉइल्ड और योर ईसीजी मशीन इज स्पॉइल्ड, व्हिच इज व्हाई व्हेन यू गेट दीज abnormal pulses, try to take the pulse manually. Okay. Review the patient's blood pressure. What is normal blood pressure range for a normal healthy individual? 120/80, that's it. For any less than 120 to 80. Decide कर लो.
Less than 140/90.
Your voice is breaking. Whoever is trying to speak online.
140/90.
140/90. Okay. Golden rule in medicine. When anyone
Less
asks you a
than
normal value, it's never one value. It's a
140/90.
range. It's never going to be 120/80.
And
That's
diabetics
the wrong answer,
130/80.
right? हमें वाइवाज में इस पे बहुत झाड़ते थे. आगे भी if you go out into clinical practice, anyone asks you what is normal, it is never one value. Because not every human being is the same, right? There is a range. So for normal systolic blood pressure, 90 to 140, right? Normal diastolic, 60 to 90. Anything below 90/60 is shock, clinical shock. That is the definition. Blood pressure below 90/60. Which conditions will you see it in? कहाँ दिखेगा तुम्हें इतना लो बीपी?
Sepsis, cardiogenic shock.
Sepsis, cardiogenic shock. What else? कुछ बोल रहे थे, आंसर करो. Hypovolemia, good. Anaphylaxis, good. Sorry? Burns patient, okay. Diarrhea, okay, depends on severe diarrhea. ठीक है, उतना fluid loss हुआ है, right? ठीक है, these are the patients that come to you normally. Dengue के complications, good. Why do we take BP for a dengue patient, right? Because हमें देखना है उसका hydration proper है कि नहीं. Your blood pressure is basically an assessment of how well your heart is pumping the blood and the circulation, right? Okay. Another way of assessing hydration, the easiest way of assessing hydration, something easier than that, online.
Skin turgor.
Skin turgor, okay. Something else on history. How do you know if the patient is hydrated? Very good. Urine output. Very good. Very simple question. They'll ask you in every entrance exam. How do you assess the hydration of a patient on history? पेशाब आ रहा है कि नहीं आ रहा है? Urine output there or not? Patient comes to you with 5 days कि पेशाब ही नहीं हो रहा 5 दिन से. एक तो उसको obstruction है. Other than that, hydration is an issue, right? In surgical patients, post-op, you will see staff nurses do this thing. They do an input-output chart. Input-output. Input is how much has the patient consumed. Output is how much is the patient urinating, right? So that tells you if the patient's hydration is appropriate or not. In which conditions is this very important? कहाँ जरूरी है to know hydration? Specifically.
In old patients, children and old patients.
Okay,
Burns patient.
Burns patient, very good. Burns patient, your major headache is getting them hydrated. अगर वो patient में पानी नहीं है, वो patient मर जाएगा. It is as simple as that. If you ever seen a burns patient, first thing the surgery resident or the casualty officer does is inserts gel coat. And large bore gel coats, green gel coat डालते हैं. These are very thick board gel coats. Why? Because you have to give a lot of fluid, right? You have to give a lot of fluid very quickly. So if you put in a smaller gel coat, if you put a blue or a pink, it will come out. Okay, so in burns patient, hydration, very important. Sorry, DKA patients also, correct. What is hypertension? कितना बीपी? व्हाट इज इंक्रीज बीपी गाइस? ये तो किसी को स्ट्रीट रोड पे जाके पूछ लो, वो भी यही बोलेगा इंक्रीज बीपी. संचित, yes. More than 140/90. Okay. Now, in hypertension, also you have different categories, right? Depending on the blood pressure, kitna bada hai, how high is the blood pressure, we categorize the patient, and according to that, we start their medication. What is hypotension? I just explained.
Great.
Mohit, I think.
Less than 90/60.
Yes, less than 90/60. Okay. That's hypotension. Sure. Okay. Next, how do you assess cardio circulation? What is pallor? Pallor. That is pilia. Pilia is jaundice. What is pallor? Icterism. Pale. The patient looks pale. That is what pallor is. ऐसा ऐसे सफेद सफेद लग रहा है, चेहरे का पूरा रंग ही उतर गया है, right? ऐसे you'll see a lot of female patients coming कि पूरा रंग चेहरे का रंग उतर गया है, ताकत नहीं है, बहुत थकान होती है, थोड़ा सा घर का काम भी करो तो नहीं होता है, right? What will you suspect the patient has? Anemia. Good.
Pallor.
Okay.
Pale. Yeah. Pale.
Okay. What is edema? Suchit, is it just swelling? Is every swelling edema?
No, fluid accumulation is edema.
Fluid?
Accumulation is.
Fluid accumulation where?
Extracellular fluid.
Edema is accumulation of fluid in the tissue space. Swelling के साथ patient आया, उसके अंदर fluid है, doesn't mean it's edema. Infection के साथ आता है, cyst बना हुआ आता है, that is not edema, right? A cystic swelling is not edema, right? So that's what I mean. If you get your basics right, you will understand why it's important. Because saying just swelling is not what edema is. It's third space fluid accumulation. If you look at your textbooks, it will say excessive fluid in the third space compartment. But that's very high fancy. Basically, tissue में जब fluids भर जाते हैं. Okay, good. I like how online people are participating. Palpation. Now you've gone to the patient. ठीक है, वो आया तुम्हारे पास, and you've gone and examined the patient. You palpated his hands. They're cold, sweaty, clammy. What does it mean? ठंडे हाथ हैं.
Less perfusion.
Less perfusion, right? Capillary refill time में तुम क्या check कर रहे थे? तुम गए, उसका finger nail तुमने pinch किया and छोड़ा, and then perfusion देखा. The same thing can be done very crudely if you touch their peripheries. If it's severe enough circulatory dysfunction, their peripheries will be cold. So if I get a patient who's unconscious, pupils are non-responsive to light, peripheries are cold, what does it mean?
Hypotension.
Hypotension. Hypotension. Pupils are cold, patient is unresponsive, no breath sounds, no respiratory sounds. मर गया है. Death.
Shock.
That is what
Shock.
death is. Dead. Shock के आगे, there is no chest sounds, there is no breath sounds. That person is gone. That's how you assess death, right? Okay, then you would do an ECG, check the flat line and everything, right? So that's how you know this will be black. This will not be red. No chest sounds, no breath sounds, not responsive, unconscious. Okay. Now this is again your triage. 5 steps of triage. Yes. See, it depends. You have 2 patients. One has less chance of surviving and the other has chance of surviving. वही तुम triage करके assess करोगे. अगर वो immediately black में चला गया, then You'll do CPR, leave the patient, and you go into, if he's red, then you will give further management, right? This is how you decide. See, when you are working in real life, it's very hard to say objective, right? अगर तुम्हारे पास 10 साल का दो बच्चे आए हैं, एक को मतलब 15 साल, whatever, two females have come with similar, with like worse condition. One has a worse condition, one has relatively mild, but you know that person, right? It's difficult for you to stay objective. This is why we have these guidelines. Ki no matter what the situation, you are able to follow it through, and everyone should get the same treatment, right? So this is why these guidelines are made. No one thinks कि हाँ ठीक है rule बनाया है कुछ reason से बनाया होगा. But being objective in your clinical practice and following those guidelines is very important. Okay, capillary refill time we've already done. Pulses. What are the pulses that you measure? Online. What are the pulses that you can measure? Radial. Okay.
So peripheral, yeah,
Go ahead.
JVP,
JVP. Okay. What is it? What is the full form?
jugular venous pressure,
Okay. What else?
and this CVP, central venous pressure.
You're just telling me pressure. Those are not pulses. You're saying it also. You're saying pressure. What are the pulses? Lot of answers in the chat. Very
So
nice.
femoral pulse, dorsalis pedis, and all this.
Okay.
Femoral.
Easy way to remember pulses. Peripheral pulses, central pulses. What are your peripheral pulses?
Radial,
Radial, ulnar, brachial. ऊपर यहाँ पे कौन सा होता है? कौन सी है? Axillary. यहाँ उसके पहले subclavian, ऊपर carotid, right? Periphery to center. Lower limb. दूर से अंदर आओ. Outermost, what can you feel? Dorsalis pedis. What else? Posterior tibial. Okay. What else? Directly femoral.
Popliteal.
Popliteal. Good. Popliteal, femoral. Okay. Got it. So have a pattern in the way you're studying. You will remember the things that way. Okay. Good. Golden rule of anytime you're assessing carotid. Normally pulse हम 3 fingers से लेते हैं, right? Carotid को कभी 3 fingers से नहीं लेते. We never do this to a carotid. How do you measure a carotid pulse? How do you assess a carotid pulse? Very nice, Ayush. Thumb. Thumb. You put the thumb. Carotid is a big artery. खुद का करके देखो. Thumb लगा के देखो, पता चल जाएगा. Right? Pulsations पता चलेंगे. Big artery, you'll feel it. In a radial ulnar, you need these fingers to be able to assess. What do these fingers do? MBBS people. What are these 3 fingers? What are they for? First year physiology, this is, guys. Okay, which one prevents backflow? This is my index. What do I do with it?
Index finger to stop the blood vessel.
Okay, next.
And middle finger to feel the pulse.
Okay, next.
And the ring finger to prevent the backflow.
Backflow, good.
So the
Middle finger feels this. Ring finger backflow. This is preventing, right? In old people, if you do this, right, and the middle finger से अगर तुम move करोगे, you can feel the type of the vein it is. You can assess the character of the vein. So in pulse, it's a very long topic, but there are a lot of things that you can assess in pulse: rate, character, all of these things, right? So these 3 fingers are very important, and they all play a role. Like no one woke up one day and they're like, हम 3 fingers से करेंगे, हम 2 से नहीं करेंगे. ठीक है? There is a reason in medicine why you're doing everything. Okay. We don't use any of our fingers to stretch the skin. That's not correct. But okay. JVP, auscultation, ankles and sacrum. JVP क्या होता है? Okay. तुम्हें full form पता है होता क्या है? What is it assessing?
Right atrial pressure.
Right atrial pressure. How does it assess the right atrial pressure? Three centimeter होती है. Okay. Jugular pressure. So your jugular vein directly comes out from the right atrium. ठीक है? और हम क्यों देखते हैं? Because it has a straight route ahead. ठीक है? तो दो टाइप की jugular vein होते हैं, internal और external. Which one do we measure from?
Internal.
Why internal?
There are no valves. It
Okay,
is
what
direct connection.
External jugular.
Why internal or why external? Okay, how many people say internal? How many people say external? Internal. अरे अभी तो आंसर कर रहे थे. External. How many people for external? 1, 2, 3, 4, 5. Doubtful 5. Internal? External. अरे अभी तो internal बोला था. पलट गए. I love it. The crowd is divided. Online भी आधे लोग external बोल रहे हैं, आधे लोग internal बोल रहे हैं. Why internal? For the people who are saying internal, why internal? Oh my God, the crowd is divided. This is so fun. ठीक है, homework. I like it. 50-50 crowd. Find out which one is it. And tell me why. Why external, why internal? Next session में बताना मुझे. Shubham, you want to answer? Unless you know the logic, you're never going to be confident in your answer. तुम भूल जाओगे. Is that why we take external? Because it's superficial? Are you sure? Are you sure? ये तो रीजन डेफिनेटली नहीं है, इतना तो मैं भी बता रही हूँ. ठीक है, फाइंड आउट विच वन इज इट. बोथ आर यूज्ड. आई लव इट. बोथ, दोनों कॉम्प्रोमाइज कर लिया हमने. इंटरनल एक्सटर्नल कोई भी ले लेंगे हम, चलेगा हमें जो दिख रहा है. बोथ. ओके, ठीक है. आई लाइक दिस. फाइंड आउट. Direct connection to RA without valve, so no dissipation. Which one? Apurva, which one? Pata. Internal jugular vein, as it is directly connected to the right atrium without any valves, therefore there is continuing column of blood. Okay. Which one? Online answer किया उसने. तुम लोग बताओ, internal या external? अरे उसका आंसर मत दिखो. ठीक है. Fine. All of you find out and tell me the reason. Online we've got the answer. Fine. Okay, moving on. Auscultation. What do you auscultate in circulation? Heart sounds. What are the heart sounds? किसी ने आके मुझे पूछा था, पता है? किसी इंटर्न ने पूछा था, मैम S1 S2 क्या होता है? Heart sounds. Okay. Heart sounds, breath sounds, S1, S2, S3, S4. Sanjit, are all of them normal heart sounds? S1, S2, S3, S4? No. Which ones are normal? S1, S2. S3, S4 किस में आता है? किस में आता है? कौन सी कंडीशन? अब नॉर्मल तो मुझे
हार्ट फेलियर
में कौन सा आता है?
S4.
Okay. क्यों आता है?
Compliance of ventricle is lost.
Yes. Okay. S3 in pregnancy. Why? Mandar, why S3 in pregnancy?
Left atrial pressures are high.
Better answer than that.
Preload is increasing
Better answer than
volume.
that. Hyperdynamic state. So any hyperdynamic state, pregnancy में heart तुम्हारा ज़्यादा pump कर रहा है. Blood उसको to the fetus also has to go, right? So that's why वही तुमने जो explain किया same ही. Any hyperdynamic condition you get S3 because cardiac output has increased, right? S3 is also normal in athletes and children. Yes. Why? I just explained the logic. Again, in athletes, it's pumping more blood. It's hyperdynamic because they need it. वो भाग रहे हैं, they're running around, they need it. Children, again, high basal metabolic rate, hyperdynamic circulation, S3. Okay. Ankles and sacrum. Now in circulation, why are we assessing the ankles and the sacrum? Online?
Dependent parts.
Yes. What are you looking for on the dependent parts? Edema. Very good, Apurva. Dependent parts for edema. Now, हमने edema पहले भी किया था और अभी वापस हम चेक कर रहे हैं. क्यों? Ankle में क्यों दिखता है? And what type of edema is it? Pitting edema. What does pitting edema mean? गड्ढे जैसा होगा. Right. Okay. So on your dependent parts, what is happening is जो fluid है वो collect होने लगता है. अगर तुम like a lot of old people are just lying, right? That is why the sacrum is your dependent part. For people who are mobile, anyone in their 40s, 50s with heart failure, पैरों में सूजन होगी. Females will come to you, पैरों में सूजन हो रही है. दम लगता है चलने में. These sort of complaints, right? थोड़ी देर चलते हैं तो फिर सांस फूलने लगती है, दम लगता है, पैरों में सूजन हो गई है. What are you suspecting? Heart failure. Third space fluid loss. Exactly. That's what edema is. But why these places specifically is because they're the dependent parts. Okay. C is done. Can we have a quick review? A, B, C. क्या था? Airway, good. Breathing, circulation. Okay. D, disability. Now, disability में you have to assess the patient's level of consciousness. अब patient तुम्हारे पास head injury का patient आया, how will you assess कि वो severe है कि नहीं है? You will assess their consciousness. There is a very easy score. Glasgow GCS. GCS on your level little difficult to do because उसमें criteria होते हैं, scores होते हैं. Very easy. AVPU. Alert. Patient is fully alert, not necessarily oriented, is fine. Verbal. Patient makes some kind of a response when you talk to them. Words, grunts, something. P. Pain. Patient responds to a painful stimulus. Supraorbital pressure. तो कभी broad dead आएगा तो उसको suprasternal pressure देते हैं. Right? To check, confirm वो broad dead है कि नहीं. Unresponsive. Does not show evidence of any eye, voice or motor responses to pain. ठीक है? AVPU. Very easy to do. Again, I'll give you an example. The same patient yesterday who came, desi daru, vomited and everything. He was responsive to pain, but not communicating. तो तुम्हारे AVPU scale पे patient alert है, ठीक है? Verbally वो कुछ बोल नहीं रहा है, but responsive to pain है. That is what we did. We were trying to assess if he is awake, alive, oriented, नहीं है कि नहीं है. You do response to pain. You try to pinch the patient, sternal pressure. All of these, do not do this in front of patient's relatives. Again, because you're trying to elicit a pain response, but the relatives will think that you're trying to hurt the patient, right? We don't want those incidents. So protecting patient privacy and making sure that the relatives are not around you when you're doing this is very important. Because it's difficult for them to understand कि तुम क्यों कर रहे हो. किसी के छाती पे जाके तुम ऐसे मार रहे हो उसको, they'll think we are trying to kill the patient, right? Okay, a more detailed score is obviously GCS. GCS में क्या क्या होता है? Verbal response. What is them? Motor response. Do you know all the categories? उसके आगे score कैसे निकालते हैं? What is the maximum score? GCS. I verbal motor. What is the maximum score of GCS?
15.
15. Right. 5 in each category. What is the lowest score of GCS?
3.
3. Why is it 3? GCS कभी 0 नहीं होता. ठीक है? That is the whole point. 1 से start होता है. This is a very common question. GCS is never 0. Below what GCS will you want to intubate the patient?
8. Below 8.
Below 8. Good. GCS तुमने assess किया. Patient below 8 है. You will move on to intubation. Very good. Pupils.
8.
Good. Pupils, what are you looking for? What does it mean? Light reflex, dilated pupil, meiosis, okay. Same yesterday's patient. उसको पहले तो pain check किया, response check किया. Then I assessed his pupils. Right side pupil is pinpoint, left side pupil is dilated. What does it mean? On which side? Right या left? Right side पे pinpoint pupil.
Medication.
Sorry? Dilated side पे hemorrhage है या pinpoint side पे? पक्का?
Head trauma.
देखा है?
Head trauma हो गया.
The site where it is pinpoint is where the hemorrhage is. Where else will you see pinpoint pupils other than hemorrhage? Opium poisoning. What else?
Horner syndrome.
Horner syndrome. Good. What is Horner syndrome?
Ptosis and anhidrosis. Meiosis,
Yeah.
ptosis, and anhidrosis.
Anhidrosis. Good. Where do you see Horner syndrome?
Lung cancer.
Okay. Never go to lung.
Bronchitis.
Cancer as the first diagnosis.
Sympathetic chain compression.
Right. Sympathetic chain compression. So any condition where there is sympathetic chain compression, you will get Horner syndrome. Okay. Patient comes to you, roadsider, multiple marks of needle injuries, multiple tattoos, disoriented with pinpoint pupils. What do you suspect? Opium poisoning. Injectable, right? Heroin. Okay. क्या हुआ? I am giving you history. हो सकता है उसको tattoo है. थोड़ा ऐसे मिर्च मसाला डाल के history देना होता है. लगना चाहिए actual patient है. The tattoos are not relevant here, but he's not afraid of needles. We're trying to establish that.
Sorry, just to ask, what is difference between opium and organophosphate? Like,
Organophosphates are fertilizers. Opium is your opiates.
drug. Yeah.
Right? OP poisoning, organophosphates, these patients will come to you with sludge symptoms. Salivation, lacrimation, urination, diarrhea, gastrointestinal, basically diarrhea and vomiting, all of that. These are farmers who will ingest organophosphorus pesticides. Opiates are injectable drugs. Okay?
Yeah.
Did you understand what the two are?
And if pupil is dilated?
You'll get pinpoint pupils. In your pupils are dilated in organophosphorus, right? Right? What is the treatment for organophosphate poisoning? Atropine. Atropine से क्या होता है?
Dilation.
Dilation, right. You will have pinpoint pupils in your organophosphorus poisoning. Atropinization, तुम atropine देखने के बाद pupil check करते हो. जब dilate हो रहा है, So that means the atropine is working. Yeah. Mydriasis, right? Okay. Drug chart review, drug history. Why is it important? I just explained. Other drugs that reduce the respiratory rate, consciousness kam karte hain. Which drugs are those? Patient has come.
Babit.
Sorry? Morphine, yes.
Barbiturates.
Barbiturates, good. Morphine will cause respiratory depression. अब तुम जब patient को anesthesia देते हो, right? One of the complications can be they go into complete respiratory arrest. ठीक है? Barbiturates, very good. Barbiturates will also cause decreased respiratory rate. Respiratory suppression बोलते हैं because it acts on that center of your brain. Okay. Exposure. Last one. A, B, C, D, E. Airway, breathing, circulation, disability, exposure. Now, in exposure, the first thing you need to know, you have to maintain the patient's privacy and dignity, and you have to conserve body heat. But in India, we very rarely do this. Examination, 4 patient hai, sabke samne examination ho raha hai. If possible, if you have less patients, try to do that when you try to give patient privacy, keep that in mind, right? Especially for female patients. If you have a separate room to examine them and things like that, it's always better to do so. Female patients, if you're a male, so when we had first joined MBBS, and in general, male doctors are asked to keep chaperones with them. अभी भी तुम्हें अगर रेडियो में एग्जामिन कर रहे हैं या सर्जरी एग्जामिन कर रहे हैं बोलते फीमेल इंटर्न भेजो, right? Because it's better कि there is a female present. It's the woman feels safer psychologically, also from a legal perspective, because then it's the doctor's word against the patient's word. Kuch hua, nahi hua, things like that, right? And it's more commonly seen with females. Males में also, it's always better to have privacy. If कोई hernia का patient आता है, हम उसको सबके सामने नहीं examine करते, right? हम side room में वो अपना dressing room में जाके examine करेंगे, things like that. Okay. Clinical assessment, exposure, inspection, head injury patient, polytrauma patients coming to you with bleeding, right? You're looking at kitna bleeding hai. That you will assess. You can see it visually दिखता है. We'll get a railway accident patient. The amount of bleeding that patient has is very different from a normal head injury patient जिसको cut लगा है, right? So visually you can inspect and see बहुत blood loss हुआ है, fluid देंगे, right? Review the patient's temperature. Why is temperature important? In which conditions and what is the normal temperature? What is the normal temperature? $25? 98. Okay. Is it only 98? What is normal temperature?
37.4 Celsius, 98.4 Fahrenheit.
Can you repeat? Your voice is not here. Either you can put it in the chat.
98.4 degree Fahrenheit or 37.4 degrees Celsius.
Okay, yes. 36 to 37.9 degrees Celsius. ठीक है?
37.4 degrees Celsius.
98 normal है, right? Okay. Temperature बढ़ा हुआ है patient का. किस conditions में? Temperature above 38.
Heat stroke.
Fever is a sign of what? Infection. Wrong.
Heat
Inflammation.
stroke.
Fever, infection and inflammation are two different things. Infection मतलब बाहर से organ
Inflammation.
and has entered the body, right? Or internally there is some infection. Inflammation is tissue injury के बाद जो होता है. There might be a patient, ortho patient, who has come to you with fever, with swelling, right? That is because inflammation हो रहा है, not because she has an infection. She can have osteomyelitis and everything. I'm not denying that. But the 5 signs of inflammation include fever, right? What are the other signs of inflammation? Redness, rubor, that is redness. Online is very active. Rubor, tumor, polar, dollar, and dollar, calor, rubor, tumor, punctulates, loss of function. Okay. Basic, this is basic pathology.
Pain, terror.
Yes. Okay. Good. So, in fact, we have established infection and inflammation, 2 different things. Fever होता है. I'm not saying infection में नहीं होता है, but the underlying cause is the inflammation. Inflammation में markers निकलते हैं. They will go and affect the same hypothalamic, your temperature regulatory center. Infection में भी it's the pathogens जो वो chemicals निकाल रहा है. The how do I explain it? The pathogen is releasing those toxins. Now those are going and affecting, right? It's the same center that's being affected. Just the way it's being affected is different. Infection में तो obviously fever आएगा ही, but it is not characteristic of infection. Not all infections will have fever. All inflammations will have, right? Because it's a sign of inflammation. Okay? And these are very old findings. This is like a historical finding. वो उसके time से Greek, हाँ, Hippocrates के time से, right? Right. Okay. So high temperature in which conditions? Hyperthermia. Okay. What else? एक ही में होता है. फिर temperature बढ़ा हुआ किस में होता है? Which cases do you get in the casualty? Malaria, typhoid, UTI.
Drug induced.
Sorry, drug induced, yes. What else? Dengue, TB, leprosy can come. Okay. These are called acute febrile illnesses. Blanket umbrella term. Acute febrile illnesses, urinary tract infections, maybe fever आता है, right? ठीक है? Okay. Chronic fever. Patient आया है, 15-20 दिन से बुखार है, उतर ही नहीं रहा है. What will you think? What does the patient have? नहीं, मतलब normal, not very high fever, not high grade fever. Apurva, malignancy, deep-seated abscess. Malignancy, yes. Which malignancy? Apurva, you answered.
Bowel cancer. Colon cancer.
Colon cancer.
Yeah, GI
Yes,
malignancies.
Lymphoma. Hodgkin lymphoma. Suna hai? Right? Hodgkin lymphoma. So they have B symptoms. That is night sweats, fever, all of this is seen very classically in lymphoma. TB also. So there is a category of conditions called fever of unknown origin. जब तुमने सब rule out कर दिया है, then you start moving to these conditions. Associated. Right. ठीक है? So that's how. No one will come with just fever. You will take further history कि और क्या है. Fever के साथ बुखार के साथ तुम ये ठंडी लगती है, हिलते हो, या अकड़ी आता है, या खांसी है. All of that associated with fever. So whenever we take history, that's why we write fever with chills, fever associated with cough with sputum, all of that. Okay? Then again, hypothermia. Hypothermia किसमें होगा? Shock. What else? Okay. वो तो shock in general हो गया. Cold exposure, drowning patients. Yesterday we had a patient. He had jumped into the water in front of gateway, right? तो ड्राउनिंग पेशेंट पानी में गिर गया है, हाइपोथर्मिया हो सकता है. We were trying to convince him to get out of the wet clothes, to get into dry clothes. Why? Because we're trying to prevent the hypothermia, right? बारिश में भीगा हुआ आया है, रोड साइडर है, from 3 days he's been getting wet in the rain, right? Likely to get hypothermia. Okay. These are actual patients that you will see, right?
What is the temperature below which it is hypothermia?
Hypothermia has a specific temperature. So temperature below 36, yeah. If you go below 36, then you'll start moving towards hypothermia. So if someone has mentioned malnutrition, right? Malnutrition, severe malnutrition, they're not able to warm themselves because उनके पास उतना energy reserves ही नहीं है. Babies, yes. Even preterm babies, you keep them in warmers, right? Because they're not able to regulate their body temperature. Case 5, okay. 40-year-old male brought by relatives to the casualty has been gasping for 20 minutes. He's a known case of bronchial asthma. What do you do? Online, anyone wants to unmute and answer?
Airway.
Airway. What do you assess in the airway?
Wheeze is present, auscultate whether wheeze is present or not.
Okay. Then,
Respiratory rate.
okay. Next.
Use of accessory muscles.
Yes. What else? Good. Anything else you want to assess in asthmatic patient?
Any skin problems?
Okay, you're moving towards the cause. Fine. Basically, it always starts with, you will never go to saturation. You'll first assess airway. It always goes like this. Airway, breathing, circulation, disability, exposure. Okay? You are skipping steps because you know कि उसको likely breathing issue hai. So you are going to breathing. This is after seeing a lot of patients. Someone who has no orientation always has to go airway, breathing, circulation, disability, exposure. And it's always better on your end also. कि तुम सब assess करो because you will miss out. Right? तुमने airway assess नहीं किया, तुमने उसको oxygen चढ़ा दिया, पता चला obstruction है उसको. क्या करोगे? Right? You're not treating the right thing because you never checked for an obstruction. Even people online, people have written saturation, someone has written rest, someone said auscultate करेंगे, right? But you never check the airway. Known case of asthma होने दो. Foreign body तो जा सकता है. Obstruction फिर भी हो सकता है. Cancer हो सकता है. Right? There are other causes also, right? Just because it's in the history. Alcoholic patient might be a hypertensive. Right? You have to know what is relevant and you have to still take the other history. Asthmatic patient, ठीक है. Don't be distracted by it. You still assess everything. Because कुछ छूट गया, that is worse for the patient. 5-year-old child comes to you. Difficulty breathing, known case of asthma, very common. You've given oxygen, दे दिया, oxygen दे दिया, ठीक नहीं हो रहा है. Could be a foreign body.
Allergy.
Sorry, allergy. Yes, could be allergic. Right? Kids will shove things up their nose very commonly. ठीक है? तो तुमने ना उसका wheeze सुना है, ना तुमने auscultate किया है. Auscultate किया तो ना अच्छा. Good. ठीक है. My point being, follow that pattern. It's made for a reason. It's made so that you don't make mistakes. Anyone has questions over the ABCDE approach? Okay. Last part, airway management. So there are different equipments. Now that you know how to do the assessment, you know how to do airway assessment. There are different things that are available to you for managing that airway. अगर वो बंदा नहीं breathe कर रहा है, airway नहीं खुला है उसका, so what do? There is something called an oropharyngeal airway. This is what it looks like. ठीक है? Udell's airway बोलते हैं इसको. It prevents tongue and soft tissue from the pharynx from obstructing the airway. Someone had said tongue before, right? So this is what it does. It prevents the tongue from falling back. Disadvantage, if it's a conscious patient, he will not want it in his mouth, right? वो बोलेगा निकालो, सांस नहीं आ रही, सांस नहीं आ रही. He'll think it's because of this, right? Again, it can cause trauma to the teeth. You're trying to put it in, the patient, seizure patient है, झटपट आ रहा है, right? You can accidentally cause trauma to the teeth. Gag reflex, right? Next, nasopharyngeal airway. Again, nasal obstruction, mouth, nose, nasopharynx में कोई ऊपर obstruction है, right? So you use a nasopharyngeal airway. Disadvantage, base of skull fracture. Base of skull fracture में, if you try to put a nasopharyngeal airway, you might make it worse. Okay, because you're trying to put it in such a way that it will go upwards, which will worsen the condition. Trauma to the nostril. With any invasive procedure, if they ever ask you क्या disadvantage है, you can always say trauma. कुछ ना कुछ somewhere while inserting can go wrong. Even if you are putting a simple gel foam, right? Bleeding हो रहा है, तुमने कहीं और डाल दिया, वहाँ पे तुमने gel को got out, पानी भर गया, all of that, right? Laryngeal mask airway. Now, all of these instruments you're likely to see in the OT. In the operation theater, they have an emergency trolley. All of this is there in the emergency trolley. In every ward, there's an emergency trolley. In the casualty, there's an emergency trolley. All these airways, emergency drugs can be seen there. So if you're ever sitting in the casualty, if you're Vela, go and see what's around, because that's all that you've been taught. Laryngeal mask airway, again, reusable supraglottic device. What is this? Favorite subtype. AMBU bag. What is the full form of AMBU? So with except breathing unit आता था. अभी पूरा आता है. Artificial manual breathing unit. Different names. It's also called bag and bag valve mask. It's also called manual resuscitator. What is this part? जो तुम discuss करते हो? This is the self-inflating bar. ठीक है? You have this. This is the reservoir. ठीक है? ये connect होता है इससे. Oxygen tube. You can also see the parts in the presentation. Oxygen tube. Face masks. Face mask. You have to seal it. You always have to make sure with the face mask, the seal is done properly. And you can hear it. Staff will often say, leak हो रहा है. आवाज आती है उसकी. कभी भी तुमने अगर एम्बू करते हुए देखा है, इंट्यूबेशन देखा है, they will always be like, कहीं से लीक हो रहा है, आवाज आती है. And you have to prevent this. Otherwise, there's no point of giving the oxygen. आधा तो बाहर चला गया, right? And then you have the oxygen inlet, you have the swivel, basically to connect all the devices. Okay. Can anyone tell me the function of the reservoir bag online? MBBS interns? You already have this to give oxygen. What does the reservoir bag do? Increase oxygen concentration. So what it does is it increases, तुमने जितना oxygen दिया ना, that will get mixed with the air, right? It increases the concentration here because the oxygen going into the body has to be more. But I'm not sure if you've seen a lot of patients using it. तुमने सिर्फ AMBU देखा होगा, AMBU और directly ET tube में connect कर देते हैं. This will increase the oxygen. Okay. Laryngoscope. Laryngoscope. How many? Okay, online poll, offline poll. How many of you have held a laryngoscope? किसने हाथ में उठाया है कभी laryngoscope? सिर्फ उठाया है. 1, 2, 3. Okay. Online. If you have used a laryngoscope or held a laryngoscope, say yes in the chat. If you haven't, put a no. Okay. No. No. Yes. Yes. A lot of yeses. Good. No. Okay. Did intubation. Very nice. Mandar has done intubation. Okay. Mixed crowd. किसी ने देखा है, किसी ने नहीं देखा है. What are the parts? Handle. ठीक है. What is this? Blade. ठीक है. Sizes होते हैं और दो type के होते हैं. एक curved होगा, one is curved. This is a Macintosh. You also have a straight blade, Miller. Where will you use a curved blade? Where will you use a straight blade? क्यों बनाया उन्होंने दो blade ऐसे ही फालतू में? मन था उनका. Online? Why is there a curved
Pediatric age
blade?
group.
Why is there a straight blade?
In children's, straight blade.
Yes. Why do we use a straight blade in children? Straight pedia, curved adult. Yes. Straight airway in pedia.
Short.
जो adults का
neck.
airway होता है, it goes like this and then straight, right? Anatomy उतना देखा होगा. In children, it's a straight airway. ठीक है? That's why we use the straight blade. It's an anatomical difference. Okay. Flange, tip, tongue. ऊपर से दिख रहा है tongue. ठीक है? Tongue. This is the hook and this is the base. ठीक है? Which hand do you hold the laryngoscope in?
Left.
कौन से हाथ से पकड़ते
Left
हैं?
hand. Right hand.
Always
Sorry.
left hand.
Non-dominant.
Left hand.
Non-dominant hand, right? If you are a lefty, you will hold it with right. If you are a righty, you will hold it with left. उल्टे हाथ से पकड़ते हैं. Good. You'll realize, you'll see. The way you use the laryngoscope, you'll realize why you use the non-dominant hand. दूसरे हाथ में, in your dominant hand is your tube, because that is your aim, ना? तुम्हें tube अंदर डालना. Okay, ET tube. Anyway, see. You can see the parts. तो ये हमारी cuffed है. On this end, you have a cuff. This is your tubing. The bevel. And you have an eye. Sorry, this side is the bevel and you have the Murphy's eye, right? Okay. You also have the markings. Okay, ये सारे markings होते हैं ET tube के. Now, what size of ET tube is used? कौन सा size का ET tube use करते हैं? अलग-अलग होते हैं, देखा होगा कभी ट्रॉली में बहुत सारे ET tube पड़े होते हैं. How do you decide what size of ET tube to use? You must have heard surgery residents saying staff 8, 8.5 दोनों ready रखो या 8 दो 8.5 दो 7.5 दो है हमारे पास 7.5 की नहीं. These are questions conversations you must have heard them asking, right? General rule 7 for women, 8 for men, but there is a formula according to the children के लिए according to the weight, but even for adults. For those who remember ENT, I don't know how many of you remember ENT. In ENT, there is a specific formula for calculating the size of the ET tube जो तुम use करते हो, because उसमें हमें intubation वो सब सिखाया. ठीक है? I will share it if you guys want to know, but again it's unnecessary. मतलब इतना detail की जरूरत नहीं होती. Rule of thumb 7, 8. ठीक है? अब depend करता है. If it's an obese patient, you can use a larger size tube. If you think it's moving too much, then use a bigger size. If it's a smaller, thin woman, you'll have to use 6.5, things like that. Okay. Tracheostomy tube. देखा है कभी tracheostomy? ICU, interns. None of the patient had tracheostomies. They were there only for a short period of time. Patient जल्दी discharge हो रहे थे. Trauma ICU. Okay, yes. Okay, some of you have seen it. Okay. Now, tracheostomy tube also has different parts. There is the outer part. You have then the inner cannula and then the obturator. Okay. Tracheostomy कहाँ पे करते हैं? What is the location? MEBS interns. This you should know. Online. Second tracheal ring. Anyone else wants to try? Below it, okay. Anyone else wants to try? T3, T4 ring. T3, T4 are rings. Tracheal, okay, tracheal ring, third and fourth tracheal ring. What else? Anyone else wants to try? तुम्हारे यहाँ आईसीयू में किसी कभी भी वो नहीं किया ट्रेकियोस्टोमी? ठीक है. Below tracheal cartilage. Okay. ठीक है. I'll show you a video on it. You guys will understand. How do you decide where it needs to be given? What sort of an incision do you take? There are different types of incision for tracheostomy. Either you can take a vertical or you can take a horizontal, right? When will you take a vertical incision? If I go into this, I'll explain a little bit. When do you take a vertical incision? Horizontal incision लोगे तो cosmetically better है. Your neck has lines on it, right? तो उसमें cover हो जाएगा. ठीक है? Why would you take a vertical incision? Emergency में vertical, right? Because if you need to extend the incision vertically down, chest open करना है, it's easier. Cosmetically horizontal. Then you assess. Okay, I will explain tracheostomy at the end. We'll finish this session and then I'll explain tracheostomy. Okay, this is like a 5-minute short video. You guys can come here, or you can see it on your phone, whatever is convenient, of intubation. Okay.
The patient should be as near as possible to the patient should be as near as possible to the receiver, and the head of the patient should ideally be approximately equal to the umbilicus at this level. Although I don't have that bed over here, so I'll just demonstrate with
Is
this.
it audible online?
Right? Now, the head should be tilted like this. There should be extension at this level. Now, this extension is at the level of atlanto-occipital. Now, to align oral axis, pharyngeal axis, and laryngeal axis, what we do is we place a folded bedsheet below the head or a pad below the head, so as to have flexion at the level of neck. So this position having flexion at the neck and extension at atlanto-occipital is called as sniffing position or barking dog position. And then you have to hold the head over here with the heel of one hand over the forehead of the patient, and you yourself has to open the mouth of the patient like this with the fingers, right? And now holding the laryngoscope in your left hand, you go inside and deviate the tongue from right to left. Now come on to the inside of the mouth. Now I'm inside. As you can see, there is the tongue which I have deviated from right to left. Now I'm going inside. I'm going inside till I see the epiglottis. So you have to go gradually. I'll show you. Yeah. So this structure, which you can see over here, is the epiglottis. And once you see the epiglottis, you just have to give a pressure. Can you see? You just have to give a pressure and you can see the vocal cords over there. Now I'll demonstrate you on this. This is the tongue. I will go like this. I will first of all deviate the tongue, and then when you see this epiglottis, so this structure, can you see? This structure is called as epiglottis, and the space between the tongue and the epiglottis, this point is called as vallicula. I have to get the tip of my laryngoscope till the vallicula. So first of all, I'll go like this, deviate the tongue, and I'll go over here. Now, the movement of my laryngoscope should be like this, as shown in this pic. So when you reach the vallicula, you don't have to twist your hand. You just have to pull it at 45 degrees angle as shown in this pic. Because if you hinge it or if you use the incisor as a lever, then you can cause trauma to the teeth or even you can break the teeth. So never twist your hand, just pull it at 45 degrees angle so that you can able to see the vocal cords over there. So those that V-shaped structure is the vocal cord, and you can see the glottic opening. Can you see it? Anteriorly is a glottic opening, and this V shape which you can see are the arytenoids. In between are the vocal cords, and posteriorly you can see the esophageal opening. So now I'll show you the zoom out version, how your position should be while intubating. So laryngoscope in one hand, just open it, go gradually inside, and I can see the epiglottis right now. I will lift it up. Yeah. So this is my hand position, like this. And with the other hand, holding the endotracheal tube after lubricating in this manner, I'll go inside, and yeah, I can see, and I have inserted the endotracheal tube till that black mark, which I discussed. Now, after this, we need to inflate the cuff of the endotracheal tube and attach the resuscitation bag. You should hold the endotracheal tube from the angle of the mouth, from this point, so that it doesn't slide inside. Now, yeah, so we can ventilate the patient. You can see the inflation of the lung. That means this endotracheal tube is inside the trachea of a patient. Had it been in the esophagus, then you would not have got the appropriate chest rise. Now, after intubating, what is the important step is I will auscultate the two apex, two bases, and then the epigastrium. That is called as 5-point auscultation.
Okay. Did you guys understand what he did and which hand is to be used?
Yes, ma'am.
Okay.
Non-dominant.
Non-dominant. Okay. Anyone has questions online? किसी को कुछ नहीं समझा? Okay. So this was essentially the last thing, and that's it. That's all for this session. Can you say 5-point? Okay. 5-point auscultation, apex of your lungs, base of both lungs, epigastrium. Why do we auscultate the epigastrium?
Esophagus.
हाँ, right. अगर esophagus में तुमने डाल दिया है तो air यहाँ पे epigastrium में जाएगा, वहाँ पे सामने. Okay. Anything else? किसी को और कोई questions?
Yes, ma'am.
3 fingers for your pulse, right? The last one, your ring finger, is for reflux. Okay. Middle finger is for feeling the pulse. First finger to occlude. Okay. Very simple. Occlude, feel, reflux. Okay. Back. तुम 3 फिंगर से करके देखो और 2 फिंगर से करके देखो. You will notice a difference. Okay. Every time now when you assess a patient's pulse, try to see what the difference is. Is it better when you do it with 3 fingers? Are you able to feel the character of the vein? Old people, they are very thin, say, hardened veins and all of that, right? So that you can feel with your middle finger. That is why we use the 3 fingers. Yes, Mustafa, the office. I'm a fan. Anyone else has any other questions? Anything you didn't understand about triage or the assessment? Is it acceptable to take arterial sample when there is no chance of vein visualization? Yes, it is. A lot of the times in burns patients especially, you will not get peripheral veins. That time we take arterial femoral blood lete hain. Directly we take femoral blood. Labs भेजने तुम्हें क्या करोगे? You can, yeah. If there are still no veins available, sometimes they'll put in central line. Peripheral veins नहीं है तो central line से और उसी से collection होता है. Especially ICU patient, you cannot keep pricking them indefinitely. सुबह शाम investigation जाने. Rima, the recording will be available as soon as this session ends. I'll just upload it and send it over to you guys. Okay. Anything else you guys didn't understand? तुम लोग जो late आए थे triage वाला मैं बाद में. Okay, that's it. If you have any other questions, you can get in touch with me on Instagram or WhatsApp. And thank you for attending. Thank you guys. I hope you guys learned. And for those here, you can look at the instruments in person. तुम लोग देख सकते हो. And those online, I hope it was good, smooth. If you guys have feedback, you can do message. Right? If you are ever seeing patients where you have doubts, for that also you can ask me. I'm available to you guys. Try doing it on Instagram though. I'll see that faster. Okay. Thank you guys. Thank you for answering and participating. It was great to see your response, and I hope to see you for further sessions as well. I will be sending the post session form. वो भर देना. We'll see how much you understood. Okay. Chalo. That's it. Bye bye. Thank you for attending.